Dear young colleagues, this is a teaching video for you of unedited phacosurgery of a cataract with grade 3 nuclear sclerosis. 2.8 millimeter main incision has been placed at a selected site. This is the side port on the left side of the main incision. You can see that the incisions are located on the posterior aspect of the limbus, and there is oozing of blood from capillaries. Now, to show the capsulorhexis clearly, I am going to stain the anterior capsule with trypan blue dye. The dye has been injected underneath an air bubble, and the dye is washed out after 4-5 seconds. Now, viscoelastic substance is injected into the anterior chamber. I am using HPMC, 2% hydroxypropyl methyl cellulose. Here it is. Now, one more side port is made on the right side of the main incision. The side port on the right side is about 2.5 clock hours away, and on the left side about 2 clock hours away. The anticapsule is incised. We can see that the capsule has been incised and a nice flap, easy to hold, has been raised. I use a Unedited forceps. The Unedited forceps presses against the anterior lip of the main incision, and the leakage is minimal, and I can complete the rhexis. In this case, the rhexis has been a little eccentric. Although it is round, it is not central. Hydrodissection and hydrodelineation has been done. Hydrodelineation in this case has produced a beautiful golden ring. Now, viscoelastic substance is again injected, and now is the time to enter into the eye with the phaco handpiece. In this case, I am going to use Oatley Cataracts 3 phaco machine. Here it is. I have entered into the anterior chamber with bevel up. Little bit of cleaning of superficial cortical lens matter has been done. Now I embed the tip into the lens matter and chop. I can hold the nucleus firmly, and it's very easy to chop. For youngsters, this is the ideal density cataract for starting phacosurgery for direct chop, even for divide and conquer. This density is ideal. It is about grade 3 or grade 2 plus nuclear sclerosis. Now, viscoelastic substance is injected into the anterior chamber. By the time my assistant gets ready with the bimanual IA, I take the lens, I take the intraocular lens, and I utilize this time to load the intraocular lens in the cartridge. Here is the lens. This is a multi-piece, 3-piece hydrophobic intraocular lens. And see how to load this lens. I am decreasing the magnification so that you can easily see this. From outside, the optic engages into the groove of the cartridge. Press right at the center of the optic and gently fold the flaps. Now, this cartridge is placed in the groove on the injector. It is advanced forward, and the trailing haptic should be like that, extending outward, not in the groove. Now I take the bimanual IA and start removing the cortical matter. This is the Oatley bimanual. and Oatly representatives claim that this is the best bimanual irrigation aspiration system in the industry. And you can see that it's probably true. In no time, all the cortical matter has been cleaned out. Now a little bit of polishing in IA2 mode, where the vacuum is only 30 and flow rate is 20. It's done. Now I am just irrigating to dislodge this loose lens matter on the posterior capsule, and it's nicely polished only by irrigation. That's it. Everything is fine in this case, except the rhexis has become little eccentric. However, it is okay. Now I have enlarged the main incision by 0.2 millimeter, and the size, the width of the main incision now is 3 millimeter. Now I want to go inside the anterior chamber, and then I have to screw out the intraocular lens. This is the Abbott injector system for multipiece intraocular lenses, for sensor multipiece as well as Technis multipiece. Now I can see that the leading haptic has gone in the capsular bag. Now I have taken a lens holding forceps, a thick, stout McPherson's forceps. I hold the trailing haptic and I gently place the trailing haptic in the capsular bag. Now I dial the lens gently with a Sinskey hook, and now I have to clean out the viscoelastic substance, that is HPMC, that I have used for implanting the intraocular lens. I am using Simcoe cannula first to irrigate out the viscoelastic substance. That white fluffy material I can flush out easily with this Simcoe cannula, because the port, if I flush, since it is on the upper surface of the cannula, it directly hits the white fluffy material and you can easily clean it out. With bimanual, the irrigation is from the side. And now I'm using bimanual IA and doing a thorough job in removing the viscoelastic substance. If we don't remove the viscoelastic substance nicely, the intraocular pressure will go up. Patient will have pain, there can be steamy corneal edema, and the patient will not be happy. So we must clean out the viscoelastic substance nicely. The side ports are hydrated very well. Care is taken to hydrate remaining on the scleral side so that I don't cause any Descemet's membrane detachment. Now this is a view under higher magnification. Look for any cotton fiber, any particulate matter anywhere. Form the antechamber nicely and conclude the case. Dear colleagues, be meticulous in your surgeries. Remove the viscoelastic substance nicely. Hope this video will be helpful in your surgical development.